Thank you so much, Ego. And I thought you were going to say, you've known me since the beginning of time, which I think the beginning of Recover it feels like that. So I'm going to be talking about some of the statistical challenges. My job here is a lot easier than the next speakers because they're going to give you some solutions to those challenges. But here I'm just going to outline what many of them are. Several of these we've already talked about in the session so far today, and we'll be hearing more about later. So first, I'll give a little bit of background about the Recover adult observational cohort study, because I'm going to use that as a framing of some of the challenges that we face statistically. So as many of you know and have already heard, Recover is an NIH-sponsored meta-cohort study that was launched in 2021 with aims that range from defining what long COVID is and what its different subphenotypes are, how it manifests, understanding its natural history and consequences, characterizing risk and resiliency factors, as well as ultimately to identify effective treatments. So there's four main cohorts that we think of within Recover: the adult, the pediatric, the autopsy cohort, as well as the electronic health record cohort. And within each of these cohorts, there are more sub-cohorts. So when we say it's a meta-cohort study, it's sort of a meta-cohort study, right? So each of these cohorts have sub-cohorts as part of them. And you can see that within the adult, pediatric, and autopsy, we have upwards over 30,000 individuals across the lifespan that are contributing data to this important observational study. So today I'm going to focus on the adult cohort, and several of the challenges that we face in adult transcend across the different cohorts, but also outside of Recover, both in the observational data as well as the clinical trials setting, as you'll see. So in terms of the timeline for adult, I just want to mention that we launched the study in October of 2021 with many of the folks here involved with it. We followed participants for up to 4 years, and we completed enrollment in June of 2024, with the last visit in October of this year. So just a few weeks ago, we had the final visit of the first cycle of Recover. We are looking at continuing Recover into a second cycle that is anticipated to launch in May of 2026. So in the adult cohort, we have close to 15,000 participants from 83 sites across the United States. At the time that they enrolled, we had 83% who had a history of infection or believed to have infection, and 17% who were enrolled as uninfected as far as they knew. Since the time of initiation of the study, 47%, so almost half of our uninfected participants, had an on-study infection that they were aware of and reported. So those we're referring to as crossovers. We have 72% female sex assigned at birth and a distribution of about 16% Black African American and 17% Hispanic. And 15% of the individuals in the adult cohort are part of the pregnancy cohort, which is a sub-cohort. And to date, we have about 18% who've withdrawn from this study. So the data that we're collecting is extensive. We have survey responses collected every 3 months that fall into these general buckets, including extensive information on symptomatology, vaccination, comorbidities, medications that people are taking, social determinants of health, as well as demographics. And then we also have clinical assessments and biospecimens that are collected at enrollment. Those little squares are actually check marks, so they're at enrollment, 3 months, 6 months, and then annually after that for some of them. So a fairly extensive amount of data, as well as biospecimens that are stored and available for additional research. The self-reported symptoms are vast, as you all know. We've heard a lot about the heterogeneity of long COVID, and in the Recover Adult study, we have reported symptoms across several different organ systems. We also heard this morning a bit about the SysBio data, so we have additional data on genomics, transcriptomics, epigenetics, proteomics, and metabolomics on about 9,000 adults and 3,000 children across multiple time points. So very extensive omics data that we're hoping to be able to leverage, both for understanding long COVID, but also it's a really unique post-pandemic cohort that has this repeated measures data. In addition to the systems bio, we have extensive digital health data. So the DHP program of Recover was designed to collect information and on the observational cohort studies, but also for an engagement tool. So participants were offered a free Fitbit to track their daily activity. And we have about 7,000 participants in Recover who've joined this DHP program. So the statistical challenges, and I want to start off by saying, it's not just long COVID, but we're also in the era of big data and machine learning. And one of the challenges with this is just the sheer vast amount of data that we're trying to leverage in this context, and the complex tools that are available to us. And I always like to emphasize the fact that we can only find what our tools are designed to look for, right? So we don't use an otoscope to measure heart rate, and we don't use a stethoscope to look in someone's ear. So it's the same when it comes to statistics, that we really have to think about what tools we're applying and what are they designed to uncover in the data. And if we don't see something with one tool, it may not be because there's nothing there. It may be because the tool that we're using is not the appropriate tool to find it. So it's really important to think about that when we're thinking about data, especially in the context of really big data and these machine learning algorithms. So before I launch into this, I just want to mention that the work that we're doing on Recover is part of the Data Resource Core, which is located at Mass General Hospital. We have a number of individuals that are here today that are part of that core. But we also have a network of biostatisticians working on Recover across the country. So we were fortunate to receive funding from the NIH to fund 8 different nodes across the country with over 50 faculty and staff biostatisticians working to analyze the Recover data, but also to both identify and solve some of the biggest statistical challenges that we're facing with Recover. So the challenges are vast. I think I have 8 of them that I'm going to talk about today, so we'll see if we get through them. The first that we're all very familiar with is defining long COVID in the absence of a gold standard. So we don't have a label. And this is a challenge in statistics. For most statistics, all of the supervised learning that we do, whenever we fit a regression model, whenever we're trying to identify risk factors, we need to have a label. We need to know what it is that represents the disease. And we don't have that here. And that's been one of the biggest challenges, I think, from a statistical perspective that has plagued us in doing analyses. So we don't have a biomarker yet or reliable criteria for determining who has long COVID and who has something else, some other underlying condition. So that's our first challenge. We heard about the National Academies coming out with a definition of long COVID. That's a broad definition referred to as the 2024 NASM long COVID definition. And this definition says that any condition that's been present for at least 3 months as a continuous continuous relapsing or remitting condition after infection is constituted as long COVID. So we tried actually applying this definition to people in recovery, where we looked at all of the person visits that we have, where people are infected or uninfected. So we count how many visits we have. So we have 110,000 visits where people are infected and 15,500 where they're uninfected. And we found that 89% of the visits that people are infected meet the NASEM definition, and about 81.5% of the uninfecteds meet it. Because people have symptoms, right? People experience things whether or not they have a history of infection. Now, of course, our uninfecteds do very likely include people who were infected. But 81.5% is obviously quite high. So we think of this NASEM definition as sensitive. It's going to pick up everybody that has long COVID, but it's not specific. It has this high false positive, likely has a high false positive rate. We have also published on an alternative data-driven strategy where we're trying to leverage what we can from the data to inform our classification of long COVID. And conceptually, what we've done here is to create what we're calling a pseudo-label for long COVID based on infection history. So the idea here is that we have our observed data, which is that whether people are infected or not. And we know that the uninfected participants are long COVID negative. We know that they can't have long COVID, assuming that they didn't have a sleuth infection. But the people who are infected are unlabeled. Some of them are long COVID positive and some of them are negative, and we just don't know which that is. So that's our unobserved data. But so what we do here is we use that information. We leverage the fact that we know the uninfecteds can't have long COVID to start getting at information about what could define long COVID. So this was published with my colleague, Dr. Tawitai, who's here today as the lead author, originally in 2023, and then was updated in 2024. And if we look again at the person visits for infected, we have about 19.3% who meet the threshold based on this index. This is called the LCRI, the Long COVID Research Index, and about 5% of our uninfected visits that meet that definition. So as many of you know, there's a trade-off between sensitivity and specificity. So again, we don't have the truth here, so we don't know what's a false positive and what's a false negative. But we do believe that something like the NASEM definition is probably going to err on the side of high sensitivity, low specificity, while the LCRI may be the reverse, right? We may lose some people, but most likely we have fewer false positives. And there really is a trade-off between these two, and it depends entirely on the context that we're talking about, which one we are most concerned about. So obviously, if there's a false positive, then we're going to introduce more heterogeneity and reduce our power for identifying associations. However, if we have a high false negative, then we're going to introduce homogeneity. We're going to make the group look more homogeneous, perhaps, than it should. So it's always a trade-off between these two. Okay, so that's one. Another challenge that we have, particularly in the recovery data, but we see this a lot also in electronic health record data and other settings, is missing data and what we're referring to as unobservable data. So in recover, we have two groups of participants. We have an acute cohort who enters into recover around the time of their initial infection, that first infection. And then we have a post-acute cohort in the bottom panel that enters into recover sometime after 30 days from their initial infection. So the rectangles there are the time of entry into the study. And then we're following them over time and measuring them every 3 months. And the open circles there are missing visits. So we have missed visits where we don't have the symptom information. We are going to hear a talk this afternoon about imputation strategies to handle that. And then we also have unobservable visits. That's what we think of as left truncated data. So when somebody joins the study and they're already 6 months after infection, we can ask them questions about what happened previously, but we're missing that information from our prospective follow-up. So we also know when we want to think about measuring long COVID, that also is going to be left truncated in this case. So if our first eligible visit that somebody could have long COVID is, say, 12 months, if they've joined the study 12 months after their initial infection, then we're missing all of the information that happened before. So if we want to think about long COVID perhaps as a burden of symptoms that we're averaging over time, then we're missing that information from those early visits for individuals. A third challenge is reinfections that can mimic long COVID. So of course, when folks have a reinfection, they could potentially have symptoms that look similar to what we see in long COVID. So we need to think carefully, and we talked about this a bit this morning with the trajectories manuscript that Bruce Levy talked about. Where, of course, a reinfection can make it look like someone's having a later onset symptom profile. So we need to think carefully about that. It also means that when there's a reinfection, we can't measure long COVID at that time. We don't know, we don't see that counterfactual of what would that person look like if they didn't have that reinfection. So we have that interval censoring there as well. And then when we do various assessments, and we're going to talk a little bit more about this, we don't always, we have variable time between the exposure, so the time of SARS-CoV-2 infection and the timing of that assessment. So for some people who are having, say, a brain MRI or a colonoscopy, that might be 6 to 12 months after their infection, or it might be 2 to 3 years after their infection. So we need to think about that time between exposure and a test. And then if we think, for example, about the LCRI or another measure of this kind of latent state of long COVID, that the measure itself is going to be time varying. So somebody may have this latent state of long COVID, but when we measure their LCRI, their index, that's going to ebb and flow over time. So it does change. And so when we want to think about modeling recovery from long COVID, we have to think about the fact that somebody's LCRI or their symptoms may wax or wane over time. And we want to make sure that we correctly define what recovery is in that context. Another big challenge in Recover, but it's also ubiquitous in electronic health record data, is what's called auxiliary variable dependent sampling. And what that refers to is when we are doing tests on people based on the existence of specific triggers. So the idea is that we heard this also in some of the recent talks this afternoon about we're doing a brain MRI or another invasive procedure on people that have particular attributes. We don't always just sample people randomly to receive those tests. They're receiving them because they have specific qualities, symptoms, labs, etc. So that's what we call auxiliary variable dependent sampling. They're sampled to do the test based on the existence of other variables. So in Recover, we have this repeated over time. So we have, at each visit, we have participants, a random selection based on various attributes offered or not eligible for a test, and some of them complete them or don't. And this is repeated over time. And we are going to hear more about this in one of the talks this afternoon as well. These tiered tests are a big part of RECOVER. They're a really exciting part of RECOVER because this is what's going to really help us to understand the mechanism of disease. We have about 30 of these tiered tests in RECOVER with a large number of people expected to complete them. So this is a big issue for how to appropriately analyze these data. Won't go into it, but the triggers of who's getting these tests are complex, just to highlight that here. And when we think about who's completing these tests, we have to think about it in the context of an observational study here. So we don't just have a sampling of people that are selected to complete the test. We also have several layers of challenges that lead up to the completion of the test. So there's potential imbalance between our exposed and unexposed individuals. So people who have an infection are different than those that don't. There are people who are not eligible to be randomized for a test, that maybe because they dropped out of the study or maybe they don't have meet the eligibility requirements. And then we have a sampling or selection to do tests, and then we have people who elected to complete the test, so we're adherent to the assignment. So we need to think about every one of those steps in doing this, and you will hear more about that. And then here's just another visual to describe the situation with the tiered testing. So here's just looking over time at an example of 6 participants, where at each visit you get an open circle if they're eligible, if not eligible to receive the test, a green if they are in that sampling pool, so they're eligible to get it. The blue are people who were selected to receive the test, and then the orange is that they completed the test. So you can see there's lots of different scenarios that we may have here over time in terms of how people ended up receiving the test. And here I just want to emphasize that if we don't consider the auxiliary variable dependent sampling, one of the drawbacks is that we may not see a difference that's really there. So this is just a way of visualizing that. If you can imagine, we have sort of some response based on a tier 2 test, and the green is people who don't have long COVID, the purple is people that do have long COVID. You see a difference in those 2 curves, but we're then just doing the test in the tail of that curve. That's all we're picking up here, because we've only selected people that have particular set of symptoms. So if we don't adjust for our sampling here, when just looked at who completed the test, it's going to look like there's no difference, when in fact there really is. So it's very important to think about this here. Just one other thing we've heard a lot about today was the different subphenotypes that exist in long COVID. So on the left-hand panel, this is work that was done within RECOVER that used a clustering algorithm to identify different subphenotypes of long COVID. And in this case, each of these subphenotype groups are distinct, so there's no overlap between them. On the right-hand side is another approach that we can take, which is looking at particular symptoms that people have. And we've heard this, people maybe have cardiopulmonary symptoms, or they have ME/CFS type symptoms, et cetera. And those phenotypes can overlap. And it's really important to recognize that any analysis that we do requires that we specify if participants can have multiple phenotypes. So if we're looking at, for example, ME/CFS versus cardiopulmonary, we need to decide whether people can have both of those subphenotypes. And of course, the advantage of allowing people to have both is that it reflects the reality of long COVID, but of course it can introduce some heterogeneity. And then finally, of course, there's multiple testing issues and multiplicity when we think about all the different possible subphenotypes. So finally, just in summary, multiplicity is always an issue when we're dealing in these contexts of big data. But it's also really critical that we are designing our investigations to properly allow us to make these novel discoveries. And this is really critical that we do this now, given how little resources and time we have. So targeting our analyses to appropriately address these questions is really critical. Finally, just acknowledgements. These are the PhD level faculty who are involved at MGH and at the Harvard School of Public Health, involved in RECOVER, and then there's a number of funding sources. Okay, thank you.
Thank you.